So I wanted to take a minute. I'm Robin Henderson, and I'm the Chief Behavioral Health Officer, and I run strategy and integration here at St. Charles Health Systems. And I wanted to welcome you all to Bend, Oregon, and relief from the rain over Denninger's in the Valley, and welcome you to St. Charles Health System, and welcome you to CCO Oregon's conference. For those of you who are staying in Bend, and if any of you need tour maps or anything like that, just see me. I'm more than happy to help. Dinner recommendations, anything like that, more than happy to help. Recommendations for good beer, go see Dr. Miller over there in the corner. But I did want to take an opportunity to thank you all for coming to Bend today. I know that's quite a drive, and I'm so glad that I can provide you all an excuse to be here on the start of a nice, lovely weekend. And also for all of your interest in talking about this very, very, very important topic. So thank you. If you need anything or have questions about our facilities, just come see me.
Thanks, Robin. As Robin said, this is CCO Oregon's Central Oregon Summit. I want to thank you guys, thank everybody here for coming. My name is Ben Hoyne. I'm the Executive Director of CCO Oregon. And CCO Oregon's been having a whole host of conferences over the past many years that I'm sure many of you have been to. And if you're not super familiar with CCO Oregon, we will kind of discuss that more as we go throughout the day here. So again, I want to welcome you. I want to send out some thank yous. First thank you goes to the Agenda Committee. Lexi Cleaver, Brian Sandoval, and Robin Henderson have done a lot of work. I want to thank those folks for putting together a great agenda. So thanks to Robin, Brian, and Lexi. Also want to thank staff and volunteers, Riley Smith, CCO Oregon's Policy Associate, Jessica Chambers, and our volunteers that are helping with us today. So thank you to them. Also wanted to thank the CCO Oregon Board. We'll do proper introductions of the board over lunch, but just want to give a shout out to all the work that the CCO Oregon Board has been doing over the last year and a half in really getting this nonprofit membership association off the ground. Also need to thank all of our speakers and our contributors. We have a good group of folks that are presenting in a host of breakout sessions this afternoon, and as we'll run through later, this room will be cut in half for the afternoon, and we'll have breakout sessions on that side and this side, and we'll properly introduce those folks as we move throughout the day again. So thanks to all those folks. As Robin mentioned, this is St. Charles Health Systems, St. Charles Medical Center here in Bend. I want to thank them very much for their support. They've been very generous in the space and the food today, and without their support, we really couldn't offer this great conference at what is relatively an affordable price as conference goes. So thank you very much to St. Charles Health Systems. Wanted to give a note of thanks to our technology sponsor, PH Tech. So PH Tech, I think it's phtech.com. They're out of Salem. They're a local Oregon technology company. So they've sponsored all of our technology today. Also wanted to thank a host of CCO Oregon members. We have our legacy members, such as the Oregon Association of Hospitals and Health Systems, Here Oregon, Pacific Source, and Novo Nordisk, who have gone above and beyond in helping fund CCO Oregon throughout the year. And we have a great host of other members that I need to thank as well. IHN Intercommunity Health Network CCO from the Corvallis area, Granger Ingelheim, Kaiser Permanente, Gobi, Moda, Advantage Dental here from headquarters in Redmond, and the Oregon Nurses Association. So thank you very much to all the sponsors that have helped make this event possible. And with that, I want to go ahead and get this day started. We have a great action-packed day, and we'll go over things more as we move along. Also, one note I want to make: we had a cell phone turned in at the front desk. So if you're missing your cell phone, it might be at the front desk. So without any further ado, I want to introduce Dr. Ben Miller. He is the Director of Health Policy at the University of Colorado, in from the Front Range here, and he'll be participating in a workshop this afternoon. But without any further ado, I'll turn it over to Dr. Miller.
Thank you. So we did the introduction introduction before the introduction to the main speaker, so thank you, Ben. To quote the great American cowboy philosopher Will Rogers, even if you're on the right track, you'll get run over if you just sit there. And I think that this room today, with the emphasis on behavioral health integration, you all are making some pretty amazing progress within your communities to try and integrate. You're trying to right or wrong, you're trying to solve the problem, but you'll get run over if you just sit there. Today's keynote speaker is an example of how not to just sit there. She actually, her entire career, and I'll tell you about the important things in just a second, she's refused to sit there, and she's pushed, and really actually challenged not only, I think, herself, her community, her state, and then the rest of us now in the country to do something bigger, bolder, and better as it relates to healthcare. So Dr. Parinda Khatri, clinical psychologist, good friend, and probably one of those people that once you meet, you'll never forget. And I think the stories that she'll share with you today, you'll never forget. Quick background on Parinda, and I think you probably can read this in your little bio sheets, or you can just Google her. That's actually more fun than hearing what I have to say. It actually might tell me things about you that I don't know. I should have done that before I got up here. A couple of roles that Parinda's had recently that I think are relevant for today's discussion is that she's the past president of the Collaborative Family Healthcare Association. CFHA is a national not-for-profit organization that's really committed to the personification of this whole thing we call integration. They are all about bringing communities together like the ones that we have here today to integrate. She's the past president of that. She also sits on what we call the National Integration Academy Council. So it's this big highfalutin group we have that's funded by the Agency for Healthcare Research and Quality that aims to give you all resources that you can use in your communities. Things like lexicons, quality measures. Parinda's been really instrumental in helping see that be successful. But probably most important, and why I think that Parinda is the right person to be talking to you at this moment in time, is that she has overseen the transformation of a state. Now she's going to talk to you about Cherokee Health Systems today, and she's going to tell you a lot of great stories about that, and make you laugh and cry and all kinds of other things in between. But Cherokee's influence on the state of Tennessee is profound. And we talked yesterday at COCO's CCO about the importance of collective impact. Well, if you think about what you all are doing here today with behavioral health integration, the collective impact you can have, Cherokee Health Systems has been the convener for her state, and now for the country, to make a collective impact on behavioral health integration. So listen closely. We're going to have a lot of time for questions at the end, but without further ado, Dr. Parinda Khatri.
Thank you, Ben. Actually, if you Google me, I don't think you'll find anything new. I kind of grew up still in that age before Twitter and Facebook and all that stuff, which is, someone like Ben is always horrified by. So if you Google me, there's really not that much, because I don't know how to do any of that stuff. We have a joke at Cherokee that if you have an immunization scar, some of us who have that, we are the people who have the hardest time with the electronic health record. So we're always like, we have a completely different orientation for those of us who have that scar. So anyway, thank you, Ben. I'm absolutely delighted to be here. Oh my goodness. That was part of your job, Ben. Was to get everything ready. And, you're really derelict in your duties. Note that down, Robin. Don't ask. Okay. So I'm delighted to be here. This is just wonderful for me because every time I come out to the Pacific Northwest, first of all, I'm struck by, it's just gorgeous here. And your air is so clean. Like if you go, I was telling Rob, you don't realize until you come to the Pacific Northwest, like how polluted things are on the East Coast, because you can see everything so clearly. The other thing is just this sense of innovation and entrepreneurship and the sense of willingness to try anything and everything. It's really part of the culture. And I think it has something to do with kind of just where you are. You're in this land of rugged beauty, and just anything that you can do to kind of be very respectful of what you need to do for your community, you do it. And so I'm always thrilled to be here. What I'm going to be doing today is just sharing with you the story from we've been doing kind of very similar work in terms of integration for about 30 odd years, and we have a lot of battle scars. Like, we've made a lot of mistakes. So I start off by that because I will kind of tell you what we're doing now, and sometimes for people it feels like, wow, overwhelming to think kind of where, kind of what we've done, but you have to recognize it's been, falling down 9 times, getting up 10 times. And so I'm hoping that some of the stories and some of the lessons learned may be helpful to you. We're all going to we have our own journey, each and every one of us, but if there's something that, in our story that can be helpful for you, that is really part of our mission. So I add this is the triumphs and trials. We've been through quite a bit with this. So this is, I come from the Smoky Mountains. So when in my breakfast in my kitchen, I can have my cup of tea and I can see the Smoky Mountains. Very beautiful, just like the beautiful beauty of the mountains here. I love seeing the 3 sisters coming on the way, Faith, Hope, Charity, then Broken Top Mountain. Is that Broken Top? Yes? Beautiful, beautiful. And like I said, the Smokies are beautiful, although they are like the most polluted national park in the country. So we've got some cleaning up to do. Okay, so this is our mission, and we start off with that. And I start off with that talking about Cherokee because our mission, I think like many of you, our mission guides us. It underscores everything that we do. Whenever we come to kind of a crossroads or a fork in the road in terms of what we need to do, what do, we go back to our mission. Is this consistent with our mission? And if you see, integration is part of our mission. It's not a program, it's not a special initiative. It is really the core foundation of our service delivery model. And that, I think, has been a very powerful part of our journey and process in this realm. Our strategic emphasis, of course, is integration of behavioral health and primary care. Outreach to underserved populations. We are first and foremost a safety net provider. So we have a saying, Cherokee goes where the grass is browner. And there is a lot of brown grass. And that's really been the driving force beyond our expansion. And we do quite a bit of training. One of the things we realized very early on is, and I think this is a national problem, and not international problem, we have nowhere near the number of healthcare providers that we need for the need and demand. And so when you look at the pipeline in general is not big enough. And then you look at the pipeline to working with the underserved and safety net, and it's like this really rusty, old, small, one little pipeline. So we really got into the business very early on of just training people because it is the best job interview in the world for us. So a lot of our staffing has come from our training. We're involved with training family practice residents. We're also co-sponsor of Behavioral Medicine Fellowship for the family practice physicians in collaboration with the University of Tennessee Medical Center. In fact, this year, the Army sent a medical director to us for a year to train in integration, and so then he's 20 years in the Army. He's a colonel. He was responsible for the entire medical corps for Africa, the continent of Africa. And now he's coming, he's in Tennessee with us, training for a year, and then his responsibility going back is going to be integration of behavioral health and primary care in the PCMH model for the Army. And so we are involved with training psychologists, psychiatrists, nurse practitioners, nurses, clinical social workers, clinical pharmacists, nutritionists. So we really do this because we know there's a desperate need, not only within our own communities, but across the country. I've yet to talk to any group of people who say, actually, we're set with healthcare providers. We really don't need any more psychiatrists or family practice. No more physicians, we're set. We're not there yet. School-based health services, one of the things we try to do is go really where the need is, and that was really the driving force behind primary care integration. But we have school-based clinics, and we also do quite a bit of telemedicine. We do telemedicine for primary care, for psychiatry. In fact, I think it's almost a full half of our psychiatric services are provided via telemedicine. But our director of primary provides almost all of her medical care via telemedicine. We have psychologists beaming in, and we also do telehealth for clinical pharmacy. So we have a pharmacy program. We actually had to get a bill passed in the state of Tennessee to be able to do that because Walgreens and CVS didn't like the idea of us doing telemed into rural communities, even if they barely, they didn't want to see the patients that we were trying to provide pharmacy services to. So we got a bill passed just for us, so we could do that. And then value-based contracting, and I know you're going to talk more about payment later today, but what we realized, this is another story, we realized is that we've got to be part of the process. We cannot be a passive recipient in terms of the payer system where we can say, all right, whatever rate, how many of us have been in that situation where like, whatever rate you want to give us, and it's getting harder and harder. So we decided, it was probably about 10, 15 years ago, the decision was made, we've got to get big, because if we don't get big, we will be eaten. We have to have clout. And so when you look at our service area, in many counties, we're it. And they have nowhere else. So here's our 14 counties in East Tennessee. Tennessee's a really wide state. I live in Knoxville, Tennessee. It's actually quicker for me to drive to Detroit, Michigan, than it is for me to drive to Memphis, Tennessee. And that always is very interesting. But it's a very wide state. And so one of the things, we started out in kind of one county, 2 counties, and nobody was listening to us. Nobody would hold meetings. And so we actually got very focused on expansion, subcontracted with a construction company, and just started expanding. And now, whenever there's an issue, they have to come to us. And so that's one of the things we really sunk our teeth into is the idea of innovative payment models for, really different type of service. So this is a little bit about us now, 57 clinical locations, 14 East Tennessee counties, almost about 63,000 unduplicated individuals. We place a lot of value on access. Access to care is very important. So about every year we've been tracking around 16,000 new patients and about 500,000, 480,000 patient services a year. So we like to be busy, and we focus a lot on providing the kind of care that we need. No, I can't. Now this is frozen. I'm going to wait for it not to be frozen. Maybe I should just use this one. Ben is going to say, this is why you should be doing Twitter and Facebook and all those tech things, because you know exactly what to do here. Yes. Well, there we go. Thank you. And so this is a little bit about our staffing. We have 680 employees, and what you'll see is we're about half and half when it comes to behavioral health clinicians and primary care clinicians. So we try to keep that fairly even. And what's been interesting is that integration is in the news big time. So I remember 12 years ago giving a talk on integration in Colorado, Denver. And people looked at me like I was just talking about, setting up auto mechanic car shops in healthcare centers. I mean, it's so weird for them. And most people just looked really perplexed. And we had like a follow-up panel, and like 2 people came, like there was no interest. So it's really interesting. The last 7, 8 years, there's just been this storm. Integration has been in the news. It's kind of been the hot topic, across the system, on the behavioral health side, on the integrated care side, in the trenches, every day. So this is a cartoon. This guy's got a knife in his back, and the doc is saying, it's got to come out, of course, but that doesn't address the deeper problem, right? And I put this in here because we've actually had people show up in our clinic with, like, knife cuts. I've had people show up with just cuts wanting to just be stitched up, and then you realize that there's a much bigger story. So it's not just about stitching people up. And so what we want to do is really think about why, from the ground up, and also to the highest level, kind of just trying to convince people, you know, we should be doing this, we should be doing this. Now that's kind of over. In general, people can accept that we need to do it. We are having a growing, more and more studies are coming out showing the clinical efficacy, showing that it is a cost-effective model of care. And more data is showing that you really cannot manage, you can't manage chronic disease without addressing behavioral health, psychosocial issues. You just can't do it. At the same time, the community mental health system, which really was, you know, burgeoning in the 1960s, community mental health has experienced, unfortunately, more and more funding cuts. Every time, how many of you are in community mental health? Every time you think they've cut you to the bone, you know, it's like you get another cut, right? I mean, what you're able to do and the funding models that you had 20, 30 years ago just are not there. And so as the community mental health centers have had to really, really narrow their scope, it's not like people got better. You know, it's not like the need wasn't there. I remember in the late 1980s, early 1990s when HMOs were really big, and they would like making big splashes because they cut the mental health services and they saved all these mental health services, and then of course their medical care skyrocketed, right? Because instead of going to behavioral health, they all went to the ER. So basically what we've done is then had to absorb people who would normally be treated in the community mental health realm in primary care. And it's always interesting to me, wherever I travel, if I visit a CMHC and they'll say, we just have this new budget cut, and then I'll go to the primary care and I'll say, do you know your community mental health center down the street just had huge budget cuts? And they'll say, we can tell. We know, because all of a sudden we have, 25 people a day calling with a diagnosis of bipolar disorder or on all these meds, and now we have to manage them. So this idea of now integrating into a patient-centered medical home that really addresses the broad spectrum of needs of people in our community has really come up to the forefront. So from the primary care perspective, it really is about finally getting some help for stuff they've been doing anyway. They've either been doing it directly and recognizing that they have been treating depression and anxiety and substance abuse all along, or indirectly, they kind of know it's been there, but they don't want to ask, because if they ask, that means they have to do something about it, so they kind of know it's there, but they don't want to know that it's there. So finally, they can kind of do something about it. The community health folks, it really now, for them, addresses pressing needs of access and the health status of the severe and persistent mentally ill. I remember, very early on, when some of these atypical antipsychotics were coming out, talking with psychiatrists and folks in mental health, and they were saying, my patients are ballooning. Like, they are gaining all this weight, I don't know what's happening, I can't get them to see a doctor, no doctor will see them because they have, a diagnosis of schizophrenia. So this has really been an interesting process for community mental health to embrace this, because they've been struggling with some, just getting decent health care for their patients. And then for payers and policymakers, for payers, honestly, when they look at where their costs are, it is with a very small percentage of people who have these comorbid mental health, substance abuse, and physical health issues. And, it's the same story wherever we go. Wherever I go in a state, if you ask the director of Medicaid commissioner, you ask the main payers in the state, and they will tell you something like 12.5% of our population eats up 83% of our costs. And it is the same story. We met with Blue Cross Blue Shield, some executives of Blue Cross Blue Shield, just for as part of our negotiations a few weeks ago, and it was the same thing. They say, we have, this percent, 7.5% of people in Tennessee are eating up 86% of the cost. And it's all the same story. So they're recognizing, hey, it can't be the same thing. We cannot have business as usual, and we want to control costs. So from that really broad view, I want to go down and just start with our story to tell you, as we kind of talk about where we are now, where we started out. So now that I've kind of set the context for you from a national kind of standard perspective on integration, this is where we started. So this is the original Cherokee office. It's a building in little old Morristown, Tennessee. And it was started by ladies who lunch. Do you have ladies who lunch? Like in the South, there's these group of women, they have lunch, every Tuesday. There's certain, and they want to do something good for the community, and they recognized that, there were children in Morristown who were not getting good behavioral health services. This was in 1964. And they decided that they were going to do some fundraising, and on Tuesdays and Thursdays, they opened up little old Cherokee Mental Health, and they named it Cherokee after a lake. If you go to kind of Tennessee, if you go to western North Carolina and East Tennessee, there's like Cherokee everything. Cherokee Lake, Cherokee National Forest, Cherokee Shopping Center, Cherokee Boulevard. And it is confusing for people, particularly when they see me, because I have my brown skin, and they're like, oh, what about your tribal work? And sometimes we'll get applications from people. My favorite is when interns apply, like students will apply, and they'll say, I'm 116 Cherokee, and that's why I want to work for you. And I think, you've not even looked at our website. We have like less than 1%. We see very, very few Native Americans who were named after a lake. So it happens every year. I always think it's humorous. So we started out this way. It was Cherokee Child Guidance Center, Cherokee Mental Health, and then what happened over time is the need grew and grew. And I have this quote, when you come to a fork in the road, take it. And this is, I think, one of the best quotes. So we end up using a lot of sports quotes in Tennessee because it's all about sports, football, baseball, basketball. So this is the thing. We had to decide that at some point there had to be a decision. Are we going to stay where we are, or are we going to do something different? And that's going to really press that demand. And this is exactly what Ben was talking about. And I think each of you are in that same point where it's like, are we going to stay where we are? Are we going to just do what we've been doing? Or are we going to really branch out and maybe even break free from some of the parameters or even perceived parameters that we've been functioning under? And so these are some of our forks in the road. So we actually started out as a mental health center. And then we started doing circuit riding. So we had our mental health folks going into rural areas. Cherokee started out in a rural area. And if you go to rural areas in Tennessee, probably like rural areas in the Pacific Northwest and Oregon, first of all, there's not a lot of space, right? You don't have much money. And so basically, where could you go to set up shop? Well, you would go to the local health department or primary care office, basically because there's no other space, unless you want to drive 2 hours to another building. And then we set up primary care operations, mostly because nobody would see our patients. Our case managers would go with our patients to their doctor's appointments, and they would overhear the receptionist saying, oh, that's a Cherokee patient. And that would mean, if they didn't want them in the waiting rooms, they would barely listen to them, and then they would not even get access to care. And so we thought, well, we need to do something differently. And so we actually set up a primary care clinic in Union Granger County. And the most famous person to come out of Union Granger County is Quentin Tarantino. So if you look at every Quentin Tarantino movie, he has someone from Maynardville, because that's where he grew up and that's where our clinic is. So now you've learned something. You need to talk about a take-home point. Go, not that I want you to watch a super violent movie, but if you ever do, that's the kind of fame in that area. We knew nothing about setting up primary care. Primary care is a really different world, and so we got we basically got two physicians, the most active of whom was 87 years old, and we, lost a ton of money, barely survived. And at that point, the commissioner of Medicaid very famously said, this is Cherokee's harebrained scheme. And they were very upset. They made us set up a different corporation because they did not want mental health funds funding medical care. So we had to do it. It was ridiculous, the kind of hoops we had to jump through. And then over time, we recognized that we just not do this separately, and we started blending in behavioral health into primary care becoming an FQHC, so we're now a federally qualified health center and a community mental health center, and we call ourselves kind of a hybrid safety net, and then really then became a behavioral enhanced healthcare home. So now we don't open a behavioral health standalone clinic or a primary care clinic. We always will open up, moving forward, we've got just integrated primary care clinics. And they're very different. Some of our clinics are just very large, urban clinics. Some are in very rural areas. And some of our clinics are a little bit, what I would consider more affluent areas. It looks more like a commercial private practice, even though we see everybody regardless of ability to pay. And then we also have a migrant health center. We have a homeless clinic. And so it's very, very interesting for us that we've been able to apply this model across the spectrum. So we like to call ourselves a behaviorally enhanced healthcare home. I'm hoping over time we can drop the behaviorally part and everybody would know what we're talking about, but we're not there yet, right? Keep saying that. And again, moving back again, we've been pushing very, very hard on the value-based contracting because we know that there is no way that we're going to be able to change the healthcare delivery system without changing the funding mechanisms. There is no way we can survive as a country with the current fee-for-service model. It cannot happen. It is the #1 cost driver, and it makes it extraordinarily difficult for us to provide the kind of care that's needed when we are working in a very fragmented piecemeal system. Okay, so now that I've kind of told our story, I hope what that's done for you is maybe helped you see where we are now from kind of the early 1960s to now when we actually have kind of the Agency for Healthcare Research and Quality actually saying there's a definition of integration. This has been a tremendous achievement. And so I always like to put this definition up here because integration has become this garbage can term. Like when a word comes out, then everybody starts using it to the point where it becomes almost meaningless, and I think integration is pretty much there. So for the behavioral health people, primary care clinicians, it's the equivalent of an NOS diagnosis. Mood disorder NOS. What is that? You could have 10 different people with that NOS diagnosis, and it could look 10 different ways. And so I think what we had to do is move towards some specificity. So people can know exactly what we're talking about. And so here we're talking about having a practice team of primary care behavioral health clinicians working together using a very systematized approach to provide patient-centered care. And so this is kind of the frame I'm working from, and I want to set that frame for you. It may or may not be exactly where you are now, where you want to go, but I'm just wanting to set this out that, basically we have a national consensus now. And so this is kind of where we want to go. This is kind of the frame. We want to take out the NOS. We've got to stop this generic word, and generic kind of I'm integrated, you're integrated, everybody's integrated. This is what it is. Okay. So what does it look like on the ground? And so I'm going to share our model of care. And again, this may not be what works for, exactly what works for you. You may take this definition and apply it, and you should adapt and apply it in a way that works for your community. The thing I loved about like this morning I took a walk on downtown Bend is you don't have a lot of chains. Thank goodness. That's so nice to see. Everything is individualized. It's really designed to meet the need of the community here, right? And so you're going to get really good food, you're going to get really good coffee and really good artwork, but it's not that cookie cutter model because it really is a product of its community, which is what we want. Okay, so our behaviorally enhanced healthcare home, what does it look like? #1, we have a behaviorist on our primary care team. So every one of our primary care teams has a behaviorist, typically a clinical psychologist or a licensed clinical social worker, and they are just part of the primary care team. We have a consulting psychiatrist, and that can mean a consulting psychiatrist on site or via telemed. Remember, we do a lot of telehealth, and we don't need a lot of psychiatry time, we found. We just need a few hours a week per clinic, and so sometimes it's just easier to have a psychiatrist in a telemed studio or in their own office, and we've population health goals. This is something that's fairly familiar to those of you in primary care. Who do we have from primary care here? Good. In primary care, you talk about patient panels all the time, right? You talk about what is the goal of the population. But in behavioral health, we don't talk about patient panels, we talk about caseloads, right? And that's really different. Your caseload is the number of people maybe you've seen in the past 6 months, or whoever's on your treatment plan review list, right? Whoever's active versus inactive or terminated or discharged from care. Primary care doesn't think that way. It's more like, here's our panel. For the behaviorists and psychiatrists in an embedded primary care system, the patient panel for primary care is their patient panel. In the clinic I work, and I still see patients, they see 19,000 medical primary care patients. So it's not just me. We have about 3.5 FTE VHCs in that clinic because it's fairly large. But every single person on that panel is my patient. I have just as much a responsibility to them as to the person right in front of me in my office in that moment, and I have just as much responsibility to someone who I've never seen but may have a need. So that's, I think, a very, very big shift, particularly for behavioral health. And then the shared support staff, physical space, clinical flow, everything is shared. You come and you see the same waiting room, it's the same flow, and this is a really powerful thing, and something that I think is often taken for granted is the concept of that shared flow and shared space. Because the minute you make it different, it's different for everybody. It's different for everybody's mind. I have this rule that when I go into one of our clinics, or get into any clinic, and we're putting our behaviorists in, particularly in the beginning, I would say, where does primary care hang out? Where does everybody hang out? And then it would usually be the nurse's station or some kind of a pod, and I would stand there, and I would go like this or this, and I would need to see the closest behavioral health space, because I needed to see the behavioral health provider from the hub of primary care. And then that actually has meant that often the behavioral health providers do not get the cushy office with the windows and the comfortable lazy boy chair and the dim lighting and, beautiful artwork, soothing artwork on the walls. In one of our clinics, it was a medication closet. And I told our BHC, who was a trooper, we actually built out the medication closet, and that was the only place that clinic was, had been built years ago. That was the only place where that person could be. And I told her, I said, you can pick any color you want to paint the walls. Okay, we can make it as nice as you want. If you pick it, it's your color, but this is where you're going to have to be. Because if you go down the hall to that office, that really nice corner office, no one will ever get you. Will not. Psychologically, we feel different. Even to the patient, you walk those 20 extra steps. The same thing is true for the scheduling, and I'll talk a little bit more about this in the clinical competency breakout, but everything is the same. My clinical schedule mirrors the clinical schedule of primary care. The nurses can schedule in my schedule. I can put people in other people's schedule, but it's the same scheduling template. So it's not having something different. So it's very easy for a nurse or a checkout staff person to schedule follow-up appointments or new patient appointments that are back-to-back, because we're all working in the same scheduling template. And it's these little things that will just destroy you if you can't get these right. If you look at these beautiful trees that you have, it's not the storms that will destroy trees. What is it? It's termites. It's like thousands and thousands of little termites that can kill a tree that has withstood horrible storms and flooding and earthquakes, and I guess you guys have fires, you don't have flooding, right? That's what I hear here. So whatever it is, this is the thing, is these little nitty-gritty details are very important, and whatever you can do to make a blended space, a blended flow, that I think is going to help you quite a bit. Okay, then the other piece of it is having behavioral health access and collaboration at the point of primary care. At the point of primary care. If it's not at the point of primary care, you're going to lose people and you lose the spirit of what you're trying to do. So, in specialty mental health, we talk about access, they say I know you probably have transportation issues, maybe people in rural areas. People can't afford the gas money to come back. They can't, think about how could you just, reorganize your day to keep coming for different appointments. It's nice to kind of be able to have access when you need it. The other piece of it is, for people when they are feeling ill, when they are needing that medical care, they need it at that time, right? So if someone is sick, and if you call, and you're a primary care provider, and you're sick, you want to be seen that day. Like, you just need to be seen. You don't need to be seen in 6 weeks. You need to be seen then. And so that's what's very, very important, is be able to meet people when they need it the most. Okay. And then the piece of this that I think is absolutely critical is the co-management of care. For those of us who have provided patient care services, how many times have you been in a situation where a patient went to see another provider and you don't know what they did? You have no idea what medicine they put you on. I don't know. It's a blue pill. It's oval. Like, you're supposed to know what that blue oval pill is. What were the labs? I don't know. What are you working on? I don't know. So there's been so much fragmentation in our system, and that results in duplication of services, unnecessary additional services, and then potentially harm to a patient. Where I've gone to communities and the medical provider is like, I have them on medicines that I later find out are directly impacted by these psych meds, or the psychologist is working with them on something and I have no idea what it is, and I would really like to be able to address that too. So this component of basic continuity of care has been very critical for us. And then the shared clinical documentation, communication, and treatment planning. We can see everybody else's notes. We have one clinical record, and that's very powerful because then we can look at the chart and see, this is what meds you're on, this is what labs have been done, this is, I want to communicate with these other providers, I will do X, will you do Y. That piece of it provides an efficiency to the system that is quite impactful when we're thinking about the day-to-day healthcare of an individual patient or a family. So what this means is, and you'll see, I'm going to use the word primary care. Behavioral health has got to fulfill the functions of primary care. And anyone who's in primary care knows the 4 C's of primary care, right? Now we have something like 60 C's. People just started adding on to it. But the first 4, contact, first line of access. You give it when people need it. Make it comprehensive. Anything that walks through the door. You cannot have your behaviorist say, I will see everyone in primary care, but I don't do substance use. I've had people say that. Like, you can't do that. If it walks in the door, you have to be able to address it. So even though it may not be an area of expertise for you, you better learn how to do it. And so I had one of our postdocs one day just showed up at my door, and it was her first case of enuresis. And she's like, I've never been trained in this before. Can someone else do this consult? And I said, actually, this is the perfect reason for you to do this consult. Right? You need to learn how to do it, because if it shows up in primary care, you have to learn and you have to be able to address it. We want it to be coordinated and we want it to be continuous. Episodes of care is a long-term relationship. This is one of the things I love about working in primary care, because I get to see patients over their lifespan. It's not just like, our traditional therapist who said, before I came to Cherokee, it was like, I will see a patient until they die or I die. They're an open case, they come forever. This is really more about whenever you need us, we will be there. It is episodes of care, and I will see people in lab waiting or an x-ray if I'm walking, and I love to hear, like, I'm doing well, or I need to make an appointment, or I need to see you because such and such happened. So there may be somebody, so just recently, I had a woman, I originally saw her because she had been diagnosed with bipolar disorder, and she was maybe 3 children, and she would get manic, she would get married, she would always put a tattoo of her latest boyfriend. I mean, she's got tattoos everywhere because it was a love of her life. She's taking her kids, they go to Missouri, they decide to stay there, then they come back. Every time she comes back, we have to help her with case management to get housing. And then what happened is she got pregnant again. So I didn't see her as frequently. I saw her very, very frequently in the beginning. You know, so for the first few months I was monitoring her very carefully. Then I didn't see her for 2 years, and she was pregnant, and she was on some meds that she could not take while she was pregnant, right? And she's like, I don't know what I'm going to do. So we got back into the, and what was interesting is they got me at the ultrasound. She had a positive pregnancy test, they did an ultrasound. She was already into her second trimester, and she did not know yet. So they immediately got me, and I was able to provide them her next episode of care. And so then she had that baby, and she was doing fairly well until about 9 months later, she had another very, very marked depressive episode. She came back to care with more, again, another episode. And the key to this is she knew that when I call, I can see Dr. Khatri that day, right? She was not someone, we have a dialectical behavioral therapy program, we have a DBT program, we would love to get her in that. We would love to have her have individual therapy, come to psychiatry. She will not do it. She will not do it. So the question is, what do you do? So our goal is we will do what fits her, which is I'm going to access care when I need it, and when I don't need it, I'm not going to access care. Besides, I know I've got to take my medicine and kind of follow these basic rules that we've set out for her. First contact, comprehensive care, coordinated care, and continuous. Those have been really critical hallmarks of our behavioral health integration model. So translating this into real world, behavioral health is a routine part of medical care. It's just part of what we do. When you come and you're a new patient with us, you get a behavioral health screen, which is like vitals, just like we do a medical vital. We'll take your blood pressure, and then we will do pre-screens for depression and substance use. It's just part of that. It's on the electronic health record. Our medical assistant does it. It is just part of our screen. It is our behavioral health vital. Then our behavioral health care is population-based. So when we measure efficacy, I always think it's fascinating. Our efficacy is not just measured in, oh, your depression symptoms are better for these 18 people who've been in this protocol. It is, what is the health status of the entire population? We have an integrated women's health clinic. Our outcome for that, where we have a consulting psychiatrist, a case manager, and a clinical psychologist working with our OBGYNs, is the number of babies who are born with good birth weights. So we're looking at low birth weights. And that is our outcome. How many babies can go home with their mothers who are not born with the neonatal abstinence syndrome? That is our metric. That is our metric. And so, again, we could look at the very specific thing for each individual pregnant woman. Did her substance abuse get, did she have better scores on the, audit, or does she have improved scores on PhD? And that may be okay, but we are looking at something broader and something that is really more kind of reflective of what we're trying to do in terms of primary care. So that's kind of the translation. I just put this here to illustrate for you when we build clinics, we don't give medication closets to our BHCs for our new clinics. These are just for the old clinics. We try to have a behavioral health consultant right embedded between the pods. And the reason they get their own consult room is because primary care is really fast, and we need to be able to pull them from an exam room. The worst thing is if you have to bring in a behaviorist and they take 30 minutes, and that 30 minutes is lost in primary care flow. I've worked with a group practice before where the consultation volume was really low, and I said, what's going on? And the behaviorist said, I don't know what's happening. In the beginning I saw lots of people, but now I don't really see as many people, and I think they value us. And then when I went to talk to the primary care providers, they said, here's the deal. Every time we get this behaviorist, I, in my mind, have to be willing to be 45 minutes behind. Because they take 45 minutes and they stay in the exam room the entire time. And they never pay attention to our flow. So we have to really retrain everybody and say, you have to be part of a workflow. There's a very delicate workflow in primary care. So the first question we will ask is, where are you on your visit? Where are you in the flow of your visit? And if we can see the person in the exam room, great. But if you're really tight, and we'll just ask the nurses. The nurses will tell you. We're backed up, and we'll pull them into the BHC consult her office is following that exact, she's right here. She's right at that BAC office. His pod is the pod right next door. He'll get her, and then she will go directly from there. She'll talk to her into the exam room, and you'll see the blue flag is out. If you can see the blue flag, and it's blue because I went to Chapel Hill, and it's Carolina blue. Every once in a while, I'll argue with our CEO as a big UT fan, and he wants it to be orange, but we're going to keep it blue. Blue for BHC. That means if you see a flag, that's where I need to go to see a patient, or our BHC is already in there. That really, I think, is very telling. This is from our women's clinic, and I don't know if you can see, but we put the blue is BHC, yellow is psychiatry, green is nurse, red is OBGYN, and all of there, then it's our case manager. And the reason this is so important is that when you have a prenatal visit, and we actually have our BHC as part of every prenatal visit because we see very high-risk women with tremendous trauma, substance use, social issues. They need, once they're dressed in their gown, the last thing you want to do is get them back dressed and going to different offices. They stay there, and everybody comes in and out. For their first visit, they will see everybody but psychiatry, and we have block scheduling. So, we may have 3 or 4 women scheduled on the hour, and then they have their own system. The nurse goes in, the BHC goes in, and it's almost like a round robin. And then once we get that covered, then we know what that person needs. But by that time, we've done a lot of health and wellness, a lot of anticipatory guidance. We have the same model for our well-child exams. So our well-child exams, we have our behavior as part of every one of them. And it's been fascinating. We've been doing that about 7 or 8 years, and we've tracked that data. It's been fascinating how many subclinical problems we've been able to identify. Is people will ask, how do I get my child to go to sleep? How do I manage sibling conflict? I would rather us deal with, how do I manage a temper tantrum? I'd rather deal with it at age 3 now than have to deal with oppositional defiant disorder at age 6 or 7. How many times have we had a patient where we're like, I wish we had just gotten this 5 years ago? And it's so much easier to intervene. And the other piece of it that we found is that if our behaviorists are involved in that flow, we actually improve primary care productivity because the behaviorists are doing all the screens, we're doing all the anticipatory guidance, and then everybody is then able to focus on their sphere of expertise and comfort. That doesn't mean that the pediatrician never talks to the families about behavioral issues. It just means we've got additional support in that area. And so basically our practitioners came to us with this. They said usually a well-child check is a 30-minute slot. They say if our BHCs can help us with it, you can make it a 20-minute slot for us. So we can do our piece in 20 minutes because the BHC has already done the anticipatory guidance. They reviewed the screen, and everything is done. They will present, they pull the patient back, and they love it. Everything has been done. They can just do what they need to do. But there's a lot that's been accomplished and synthesized for them before they walk into the room. And so essentially for our providers who see kids, we've got an extra 20-minute slot every hour. So even though we don't get paid additionally for that well-child check, we actually have increased our revenue because of the way we structured the flow. So when you think about the behavioral health consultant, what they do and what they shouldn't be doing, we see a much broader spectrum of issues than would typically be seen in specialty mental health. Management of psychosocial aspects of chronic and acute diseases. Very often, probably the most common is diabetes, psychoeducation with diabetes, self-management in diabetes. When anyone even just gives a patient a prescription, you've asked them to change about 7 behaviors. You got to take the prescription, you have to go to the store, you've got to get it filled, you have to remember to take it. Have you seen some of the medication regimens our patients are on? Could you do it? Some of our patients are on like 18 medicines, some are TID, some are BIT, some are with food, some without food, and then we get frustrated because they're, quote, non-compliant. I mean, it's crazy. So a lot of it is helping apply behavioral health principles of change to health behavior change. How can we do this to help you implement the changes to self-manage your help in a more adaptive fashion. So we get pulled in for quite a few kind of what you would consider physical health issues. Recently, it's been a string of migraines for me. I've had a lot of people with treatment-resistant migraines, which are debilitating. But there are some behavioral changes that you can do to help improve that. GI issues are huge. Weight management, smoking cessation, application of behavioral principles of change to lifestyle factors. In Tennessee, and Ben Miller was born in Tennessee, he'll tell you, like, we just eat really fatty foods. You know, it's just, everything comes with fat back. If you know what fat back is, just fat. It's, you know, fat of a pig is just thrown in with any greens. And they'll have just really high fat foods. So obesity is an issue. We developed a pediatric obesity prevention and at-risk intervention program about 5 years ago, because when we looked at the rates of pediatric obesity in our system, they were double the national average. And so then at every well child check, we built into our electronic health record, if a child comes in with a BMI at the 85th percentile or higher, get the VHC. We actually tracked, we worked with a nutrition professor, nutrition UT, fruit and vegetable intake, activity level, and screen time, readiness to change. And between 1 and 3 sessions, we were able to work with the family. And we've been able to show every year statistically significant reduction in ZBMI, which is standardized BMI. You have to look at ZBMI with kids because they're also growing taller. So you can't fake get credit just because they got taller and their BMI went down. We made it hard for ourselves. We wanted to standardize it. And every year we were tracking it. What we found is 2 behavior changes gave us the biggest bang for our buck. The biggest bang for our buck is, number 1, reducing sweetened beverage intake. We could not believe how much sweetened beverages these kids were taking. Kool-Aid, sweet tea, soda, all these things with sugar, they were basically guzzling all day. And the second thing was reducing screen time. And what you find, and this is what the data shows, is if you even just reduce screen time, you don't even have to make them be active. Just by doing something else, by being in front of a screen, kids lose weight. They find a way of getting active in another way. And so those 2 things we realized could be very powerful. So now, that's what we focus on. Very, very simple things for us to say. Instead of having Kool-Aid, how about water with a little bit of juice mixed in? Or, you know, one hit that we found is the kids love the fizz of soda, so sparkling water with a little bit of apple juice or something, just so they can get the fizz. And that made a big difference. The primary care environment is a perfect way of doing that. And what you find is that brief intervention in primary care for this one kid will change the trajectory. These are kids whose parents have diabetes. Their parents are morbidly obese. Their parents have hypertension. So we want to change that trajectory from really a lifetime of needing to be on medications and struggling with all the health sequelae of obesity to potentially not needing that. Think of the healthcare savings. Think of the quality of life changes. You know, it's tremendous. I will tell you, the most striking patient I had, she was 8 years old. She was 240 pounds. She was like the sweetest little face. Oh my goodness. She was just like a round, you know, ball. She was the sweetest little face, and the kids at school used to call her Miss Piggy. And it was devastating for her. And her mother was also very heavy. Her mother had the baby, and they would have those big supersized sodas. And that was one of the first things I noticed when they came to the medical visit, is she had a bag of Fritos and a supersized soda that her mom would let her get. And so just by changing that, we were able to make huge changes. And she was going into middle school, which terrified me, because we all know, like, there is nothing more vicious than the middle school world, right? There's nobody more vicious than the middle school. So we said, all right, we've got like 6 months to try to help. She was going to be on metformin. You know, her pediatrician said, I got to put her on metformin if something doesn't change. And so now you can see her pretty face. You know, now you can do that. So those have been very critical things that as a behaviorist we can bring and blend into the primary care environment. I could never have done that if I was in the specialty mental health sector. I could never have worked and done motivational interviewing explore some of the issues, right? And then finally, consultation and treatment of mental health disorders. That's the biggest thing. When you first put in behaviors in primary care, they're just like, you're going to see my most difficult patients, right? And these are people who are high somaticizing, chronic pain, substance use, drug seeking. And my favorite, they don't know what access to borderline really is. They just know that every typical patient gets that. It's like, oh, she's borderline. You just talk about another garbage can term. If you ever want to put the scarlet letter or target on a patient, just have anybody on the healthcare team say they're borderline or they're difficult, because that just means that people are just going to have cringe when they see that. And so that's one of the first things that you'll get. And I'll tell our behaviorists, just know for the first 6 months, you're going to get the most difficult people, because providers don't know what to do with them. They don't know what to do with them. And so this is something that's going to be really critical. Be comfortable with this. Know how to work with this. So the scope is quite broad. And so when you think about kind of what this looks like in an integrated system, it's actually very flexible and dynamic. One of the most common questions I get is, well, how do you know who comes to see you versus specialty mental health, and how does that work? And what I will tell you is it needs to be as flexible and dynamic as any other specialty mental health primary care collaboration. So in primary care, we'll do a consultation, we'll do an assessment. It may be that for most people, in fact, for over 80% of the people, and I track this actually every year, for every one of our clinics, I get data on, and actually now I'm moving to quarterly, the percentage of people who are referred to specialty mental health, and it's anywhere between 15 to 20%. 15 to 17% was my most recent numbers. So what you're saying is, for most people, they can respond to brief targeted interventions. There's some people who will need specialty mental health. They'll just need it. And our job is to smooth the way and help them get there. And the key is really assessing level of engagement, level of pathology, level of readiness to change, because the biggest mistake you can make is just go by need. There are a lot of people who need specialty mental health who do not go. What will they tell you in the exam room? They will say yes, right? They want to please the provider. They're like, yes, I'll take it, yes, I'll do it, and you'll believe it, boy, do you believe it. And then they don't go. The data tells us more than half don't go, because it's really scary to take that number and take that card and make the appointment, and the appointment is so long, it's far away, and then you got to get there. Then it's a strange person. You got to fill all this paperwork out, right? So we have to say, how engaged are you in this? This is what it's going to need. Is this something that you think you can be involved in and be an active participant in? And are you ready for this? And it's really interesting to me, unfortunately, people who will say, I'm not ready. I just saw a woman, she had been raped. She'd actually been raped in another city. She worked at the airport, and she was raped in the bathroom. It was horrific. And she worked there for 20 years, and she just left and came to Knoxville. And she was having significant trauma reactions, but she said, I'm not ready. I'm drinking. She was drinking heavily, and she said, I want to focus on my drinking, and even though this stuff, other stuff is there, I just can't